Thank you very much. I want to also thank Edgardo and the program committee for inviting me to speak to you about immunotherapy in genital urinary cancers. As you know, there's been substantial progress made. I'm going to devote most of my talk to renal cell carcinoma and bladder cancer because that's where most of the major achievements have been made. So in terms of immunotherapy of prostate cancer, we have one FDA-approved immunotherapeutic agent, which is sipuleucel T. And as you know, this is a dendritic cell vaccine. Mononuclear cells are harvested from the patient. They're complexed with dendritic cell precursors, and then ex vivo, they're allowed to mature, and then they're reinfused back into the patient, activating T cells, which are endowed with the ability to recognize membrane-bound prostatic acid phosphatase on the cell membrane. And this was the second large trial reported in 2009, the IMPACT study, that showed again that sipuleucel T extends median survival beyond 2 years, so very durable responses to this. You can see a overall survival of 25.8 months versus 21.7 in the placebo arm. There was some crossover on this trial that was allowed in about 64% of the patients. And as you know, one of the problems with sipuleucel T is that we don't have a biomarker that we can use to assess response to therapy. And we know that the activation of the immune system can vary over a significant period of time in patients. And so often we're following PSAs after treatment, and they're on to some other medication at that time. And nevertheless, we can carefully select patients who would best benefit from this type of therapy. And you can see here in this retrospective analysis that patients in the lowest PSA quartile had substantially better overall survival than those who had PSAs that were quite high. In fact, if your PSA was under 22, the overall survival was about almost 9-10 times that what it would be if the PSA was entered onto this medication with PSAs over 134. So low tumor burden, minimally symptomatic patients, patients with a PSA of 20 or less, those are going to be the patients that are going to benefit the most. Another vaccine is relimagine. This is a pox virus vector that's been activated. The adjuvant is GCSF, but the target here is prostatic-specific antigen rather than prostatic acid phosphatase. This is very old data now that Phil Kantoff presented a number of years ago showing a similar in a phase 2 study survival benefit with relimagine versus placebo. And this particular study, the PROSPECT study, is one that we're anxiously awaiting the results of. These are patients that are similar to the patient profile for sipuleucel T in that they are minimally symptomatic, have low tumor burdens at treatment. And the randomization here is to relimagine with an adjuvant GM-CSF or an adjuvant placebo with the vaccine or a vector placebo itself. There was no crossover design here, so patients went over to standard care. So this data is likely going to be reported out in the fourth quarter of this year, and we await the results anxiously. One question that comes up is there a role for PD-L1 blockade in the treatment of metastatic CRCP? Needless to say, it's been extremely disappointing. I think prostate cancer really has a low mutation rate, and it's difficult to get these infiltrating T cells, these CD8 cells, into the tumor. The phase 1 trial with nivolumab looked at 17 patients. There were no responses in any of these patients. One intriguing lead, though, was to try to find a way that we could upregulate PD-L1 expression on the cancer cells. And this was work by Kathy Bishop and the group up at Vancouver that showed that upregulation of PD-L1 expression occurred in enzalutamide-resistant preclinical models, and this was not something that was AR splice variant 7 driven. So there was a recent phase 2 trial done by the group at Oregon that showed unexpected clinical activity when pembrolizumab was added to patients who were progressing or beginning to progress on enzalutamide. And the biopsies of these patients, interestingly enough, did show presence of CD8 tumor infiltration into the tumor. This was an article that was published by Julie Graff at the University of Oregon testing this concept out. And in the first 11 patients they treated, I show 3 that responded, but very high PSA levels. The third patient there had a PSA of over 2,500, and after treatment, almost undetectable by ultrasensitive methodology. 2 of these 3 had measurable disease. The best response was a partial response. There were some attempts to look at microsatellite instability to see if this might also affect response. The prior treatments on these patients included either abiraterone and enzalutamide or enzalutamide alone. This is an example of a patient who had nodal involvement on your left with a clear response. The second patient had visceral metastasis in the liver, a cavitary lesion that you can see there in the right lobe, that by week 12 had decreased significantly in size. This is a clinical trial that's beginning looking at enzalutamide, and in this case, atezolizumab versus enzalutamide alone. These patients can have had abiraterone or docetaxel, and then there was a safety run-in with atezolizumab and enzalutamide, and then a one-to-one randomization between enzalutamide and atezolizumab versus enzalutamide alone. Moving on to renal cell carcinoma. This is an often forgotten treatment, high-dose interleukin-2, but we have to remember that this was approved by the FDA back in 1993. It was the work largely out of the National Cancer Institute. It was reported in the JCO by Yang and Associates back in 1993. And interleukin-2 would today kind of work in the priming stage where the APC is being presented to the T cell. It stimulates T cell proliferation and function. It augments natural killer cell activity and cytotoxic activity, and it triggers release of cytokines, including interferon gamma and tumor necrosis factor from activated lymphocytes. And we all saw those pictures in the old days of these activated natural killer cells coming face to face with the tumor. I think it obviously is still a viable a treatment option. The initial study had 3 arms, but the high dose versus the low dose were the important arms. And you can see that the curves remained the same and did not diverge until a while later, in about 2 or 3 years sometimes. And then they flattened out. So we had these long-term responses that were really considered cures after a while. In those days, patient selection isn't what it is today. So today we're doing a little bit better with patient selection. And what are those patients? Well, common sense. They're good performance status patients. They've had no prior cardiac or pulmonary comorbidities. These were clear cell histology patients. Portions of the MSKCC prognostic indicator score were used. These are normal hemoglobins, normal calcium and LDH were favorable. A longer time from initial diagnosis to onset of metastasis. Very importantly, proximity to an IL-2 specialty center. As you may know, capillary leak syndromes and third spacing are something that requires a lot of intensive care unit management, and you almost need a nursing ratio of 1 nurse for every 2 patients. You obviously have to be close to a center, and the patient has to be motivated to get this type of treatment. There is also evidence that interleukin-2 may be synergistic with PD-L1 therapies, and that they restore or revigorate depleted T cells. And the response rates to immune checkpoint therapies after interleukin-2 is preserved. It's still very good as to what it would be if these patients were treated up front with checkpoint inhibitor therapy. This is the CheckMate 25 phase 3 trial of nivolumab and everolimus in advanced renal cell carcinoma, a very important study that led to the first approval for a PD-1 antibody in this disease. These patients had advanced renal cell carcinoma with a clear cell component. They could have had one or more than one prior anti-angiogenic therapy, so in a sense it was mostly a second line but also a third line type of treatment. And the patients had to have progressed within 6 months of TKI therapy. The randomization was 1-to-1. Many ask why was everolimus chosen as the comparator arm. That was the standard of care back in 2011, 2012. Drugs like axitinib weren't around at that time. The primary endpoint was overall survival, and the key secondary endpoint was overall response rate. This was the overall survival at the first interval analysis of survival. And you can see in this case, as opposed to interleukin-2, there's a very quick separation of the curves at 3 months that's maintained for the duration of therapy. And when you hit the 2-year mark, about 52% of the patients on nivolumab were alive versus 42% with everolimus. The hazard ratio here was 0.73, so a 27% risk of reduction of dying if you got nivolumab versus everolimus. And if you look at the intermediate and poor prognostic risk groups, there were only 16% of patients in the poor risk group, but the most robust difference between the survival was in that group of patients. If you look at the number and sites of metastasis, whether this was oligometastatic disease or multiple sites of involvement, which was the case most of the time, or whether they had bone involvement or not, or liver metastasis or not, the hazard ratios favored nivolumab over everolimus. If you looked at prior therapy, the two standard of care medications at that time, sunitinib, pazopanib, the hazard ratios were favoring nivolumab. The number of months on first-line therapy, less than 6, so almost inherently resistant to first-line TKI, or patients who had had a prolonged effect benefit still had a good benefit from nivolumab. And the number of prior anti-angiogenic therapies also favored nivolumab. Where I think the field is moving now is clearly immunotherapy combinations. So PDL or PD-1 blockade with a second checkpoint inhibitor. This would usually be something that worked earlier in the immunology cell cycle. The use of VEGF blockade, either VEGF antibodies or receptor tyrosine kinase inhibitors with PD-1, PD-L1 blockade, and finally PDL or PD-L1 blockade with cancer vaccine therapy. This is still a work in progress, or even with radiation therapy. So why use combination therapy? It makes a lot of sense. A drug like ipilimumab blocks CTLA-4, so it actually enhances the activation of T cells after presentation of a tumor-specific antigen to the T cell, whereas, as we know, PDL blockade works way downstream when you're dealing with the interface of the cancer and the CD8 or tumor infiltrating lymphocyte. So it would make sense, and we're going to hear a lecture after mine on Nivo and IPI and melanoma. I'm just showing you this slide because this is very mature data showing a huge difference for the benefit of adding Nivo and IPI in this tumor as a couplet in this disease. This is the trial design of CheckMate 214. So this is a trial that utilizes the same concept, nivolumab and ipilimumab in metastatic renal cell cancer. These are patients with clear cell histology who have failed on prior TKI therapy. They have a chromatography performance status of greater than 70. The doses are shown here, and the comparison is the combination versus sunitinib standard of care. And the patients are treated in this trial with until they progress or until toxicity prohibits them from continuing on to treatment. Why think about VEGF inhibition with PD-L1? Again, they're involving different aspects or different stages of the cell cycle. So if you have a drug like bevacizumab, it's going to have an effect on the tumor microvasculature, and it just might help promote more infiltration of T cells into the tumor. Normalizing tumor vasculature, permitting tumor cell immigration into the tumor bed, promoting inhibition of inhibitory dendritic cells, and the anti-tumor effects of VEGF inhibition itself will lead to programmed cell death. This is a study of atezolizumab, a PD-L1 antibody with a VEGF antibody, bevacizumab, a very high in the preliminary study, a very high overall response rate of 40%, more than you would predict historically from either of these medications alone, and it was well tolerated. And there was an early indication that the duration of benefit would be long. If you look down in your, right corner, you'll see stains that show the infiltration of the tumor-infiltrating lymphocyte into the tumor. And if you were on bevacizumab and atezolizumab, about 89% of patients had enhanced immigration into the tumor from these activated T cells, as opposed to 14% if they had monotherapy alone. This trial was completed, the phase 2 trial of atezolizumab and bevacizumab versus atezolizumab alone. It was presented at the Kidney Cancer Foundation last year and then at ASCO GU in February of this year. These were patients with clear cell histology who were randomized to atezolizumab plus bevacizumab versus atezolizumab alone versus sunitinib alone. There was an option to cross over to the combined therapy if you didn't get randomized to that in the initial randomization. The overall endpoint in this trial was progression-free survival, and the secondary endpoint was overall survival, duration of response, and safety. The combination did not show a statistically significant difference in progression-free survival when it was compared with sunitinib. However, if you looked at patients who had substantial PD-L1 expression, the combination in this subset of patients reduced the risk of disease progression by 36%, and the median progression-free survival was almost double in the PD-L1 positive group compared with the Sutent arm. So the difference was 14.7 versus 7.8 months. And so there is a phase 3 trial, Emotion 151, that's currently evaluating the benefit of this combination as a first-line therapy in metastatic RCC with PD-L1 positive patients. This is another trial looking at a combination of a TKI with a PD-L1 antibody, avelumab, which is the same class as atezolizumab, and it was shown that you could safely combine axitinib with avelumab in a study such as this. There was a dose-finding portion of this, and then a run-in, and the trial design was to look at the combination of axitinib and avelumab with axitinib alone. And the primary endpoints were overall survival, duration of response, and overall survival. What we can see here is that there was a substantial overall response rate of almost 60%, which is much higher than we would see with single-agent historical controls. And the response rates were more pronounced in patients who had PD-L1 expression than those defined as 5% or more, and in the immunohistochemical staining compared with those that had lower expression. The safety profile, the profile of taking a TKI and combining it with a checkpoint inhibitor was very well tolerated. We had so many problems in the old days with some of the other combinations with the mTOR inhibitors. So this data is ongoing in a phase 3 trial, which is investigating the combination of avelumab and axitinib versus sunitinib alone in untreated metastatic clear cell RCC. This is another trial looking at axitinib with the PD-1 antibody pembrolizumab in patients with metastatic renal cell carcinoma. And I would draw your attention to the fact that the response rates were quite high in this combination, again, more than we would see with historical controls. The median progression-free survival was a respectable 15.1 months, and the duration of responses has been long. The progression-free survival has not yet been reached, so this is an ongoing trial. Moving on to urothelial cancer, this is an area that's had tremendous progress in the past 14 months, basically. We knew even back in the 1960s that there was anti-tumor activity to adjuvants like BCG. BCG was a vaccine that was developed back in the 1920s, and it stimulates, as you know, a very brisk inflammatory response. It's made from a strain of Mycobacterium bovis. It causes inflammation. It was the first indication that maybe immunotherapy would be useful. It's still relegated to patients with carcinoma in situ or high-grade, non-invasive bladder cancer. But then you fast forward to 2016, and in the spring of that year, and this is what it looks like. This is remarkable. In this time period alone, 5 new checkpoint inhibitors were introduced beginning back in May of 2016 with atezolizumab, and then in February, nivolumab. And in the first 2.5 weeks of May, 3 more, durvalumab, avelumab, and pembrolizumab. This was the trial that led to the accelerated approval of atezolizumab, and it was broken down by cohorts of cisplatin-ineligible patients and platinum-eligible agents. So these patients would get typical gem-cis, or cis-gem, or they would get maybe dose-dense MVAC or some other variant. And the standard dose, 1,200 milligrams IV every 3 weeks. The patients in cohort 1, again, those who were platinum-ineligible, were treated until unacceptable toxicity or disease progression. In cohort 2, they were treated they were treated after failure of platinum-containing regimens, either until unacceptable toxicity or radiographic or clinical progression. The primary efficacy points, and I think this is important, really didn't have to do with median or overall survival at this point. The objective response rate assessed by a modified RECIST criteria and the duration of response were the main efficacy endpoints. The patients who are cisplatin eligible in this population, as you know, tend to have poor renal function. They may have peripheral neuropathy, ototoxicity. Many of them are smokers. So that's a substantial number of patients that would make up the cisplatin ineligible arm, and it was really important, I think, to look at that population and from a practical standpoint, if you're in clinical practice. Even peripheral neuropathy and hearing loss, as you know, is not uncommon in this group. And the platinum-treated patients had a good creatinine clearance and none of these other toxicities. And this is a survival curve. I'll just show you briefly. This was not a main endpoint of the study, but you can see a pretty good response in the cohort that was being treated in the second line who had prior cisplatin and gemcitabine versus those who were treated just with the cisplatin up front, but still substantially better than other regimens such as carbo and gemcitabine might be. And again, going back and focusing on the main endpoints, there was an overall response rate of 14.8% for all 310 patients. If you look at PD-1 expression, atezolizumab showed an overall response rate of 26% if the patients had greater than 5% staining for CD8 cells on their tumor specimens versus basically half of that, or almost half of that, in the patients who expressed a lower rate of expression. So in this case, PD-1 expression, I think, does make a difference, even though it was not required by the study at the time. And there were patients that were either unaccounted for or had very low levels that responded. But the median duration of response was not reached, and I think that's why this medication got the accelerated approval it did. That being said, because the primary endpoint was not overall survival, the INVIGOR 211 study was done with atezolizumab. This time, again, a similar group of patients who had progressed on frontline platinum therapy, who had a good ECOG performance status and evaluable tumor samples for PD-L1 testing. And the randomization was to atezolizumab or the investigator's choice of second-line therapies, which has historically been either taxane-based or platinum-based, taxane-based. And then this vinflunine is a medication that's a vanca alkaloid that was active initially in Europe and then reproduced efficacy in this country, and so it had an accelerated approval. I don't think many of us have used that yet in the second-line setting, and probably less so after I present some additional data. This was a trial of nivolumab monotherapy in metastatic urothelial cancers who had received patients who had received prior therapy. The checkpoint 275 study, again, these are patients who progressed on frontline platinum-based therapy, had evaluable PD-L1 for staining, and had metastatic or locally advanced disease. The treatment was nivolumab at 3 milligram per kilogram IV Q2 weeks, because at that time we didn't all use the standard 240 milligrams IV that we use today. And they were treated until progression or unacceptable toxicity. The study endpoints here were overall response rate, again, and patients who had various expression rates of PD-L1 and either greater than 1% or even greater than 5%. The secondary endpoints were progression-free and overall survival, and safety and quality of life and biomarkers associated with efficacy were other secondary endpoints. This shows the response rates, which was one of the primary endpoints, and I think that was a respectable 20%. But again, you can see that if you enrich for patients who have high PD-L1 percentage staining, it's much higher, about almost 30%. And the best overall responses were shown here. Again, the complete response rates are typically low. Partial and stable disease makes up a substantial amount of the group, however. And this is the survival curve. Again, on the top in orange, you see the median overall survival being better for PD-L1 enrichment greater than 1% than a lower amount of PD-L1 staining. And then in all treated patients, there the median overall survival being 11.3 months with the high PD-L1 expression. This is just a conclusion slide that's summarizing, again, what I said, again, focusing in on the higher PD-L1 expression and numerically higher overall response rates and overall survival. The safety was acceptable in what we typically see in terms of autoimmune complications and endocrinopathies. This is the KEYNOTE study. This was an important study looking at pembrolizumab. Again, If you look at the design of this trial, it's similar to atezolizumab. So these were patients who were treated with frontline therapy, platinum-based, either MVAC-based, or more commonly cisplatin and gemcitabine, good performance status, and they were able to provide tumor samples for biomarker assessment, which was important. The randomization was to pembrolizumab versus any one of these three, paclitaxel, docetaxel, or the vancomycin vinflumin. And the key endpoint was overall survival and progression-free survival, and assessment of subgroups by PD-1 expression. And the secondary endpoint was overall response rate and duration of response. The response rates were clearly better for pembrolizumab than these three chemotherapy agents, each one of them. Almost twice as many people responded on the pembrolizumab than they did on second-line chemotherapy. And if you look at the survival curves here, you see a clear separation of the curves beginning about 4 months and maintained. 43.9% of patients were alive at 1 year, actually at 2 years, and 30.7% at 2 years, and the median overall survival was 10 months for pembrolizumab versus 7.4 months for chemotherapy. So in the second-line therapy, this was an example of a checkpoint inhibitor actually beating out second-line therapy in urothelial cancers. And this is the overall survival by subgroups, looking at, again, PD-L1 expression, looking at prior chemotherapy, looking at visceral organ metastasis, and about 2/3 of patients had that, looking at, having trouble seeing that, smoking status. And this, again, is a summary slide showing significant improvement in overall survival over chemotherapy. Those are the hazard ratios we talked about. There was no difference in progression-free survival. There often is not progression-free survival benefit for immunotherapeutic agents. It's mostly overall survival. And the overall survival rate, shown here again, 2 times as likely to respond as, with pembrolizumab than with chemotherapy, and a lower incidence of treatment-related adverse effects, which in the second-line setting is very important in this group of patients. Immune-mediated events was similar to what we would see with this class of drugs. This is the drug durvalumab. This is in the same class as pembrolizumab and nivolumab. It's a PD-1 antibody. There was interest in it early on. Again, a similar trial design, progression on therapy during or after therapy with a platinum-containing regimen. The dose is 10 milligram per kilogram every 2 weeks. And the primary endpoint here was, again, looking at safety and tolerability, overall response rate, and duration of response. This is a common theme when these agents are being studied in phase 1, 2, or phase 2 studies of looking at overall response, safety, and duration of response. They were very interested, the investigators, in looking here again at PD-L1 status. The overall response rates were shown here, 17% overall response rates. This is similar to what we've seen with other PD-1 and PD-L1 antibodies, a small proportion having complete responses, the remainder having partial responses. The overall response rates, however, together were among patients who had received a prior neoadjuvant therapy or adjuvant therapy was interesting to me. It was 24.3%. The duration of response is a very important issue with these medications, was fairly durable. About almost half of the patients were alive at 18 months, and we've seen that with the other checkpoint inhibitors. And We've all seen kind of these flattening of the curves as we get to the 18 and 24-month period of time. And again, if you look at PD-L1 expression for this particular agent, very much higher, 26.3%. If you were a high expressor of PD-L1 versus low or no expression, 4.1%. A number of these patients were not evaluable. They had the opportunity to look at archival specimens afterwards, and it really supported the PD expression. I'll finish up quickly here. Avelumab, again, this is similar to atezolizumab. It's a PD-L1 antibody. This is a Javelin trial, again, looking at patients who had progressed on platinum-based regimens. You can see the overall response rates as being very similar to the other studies and checkpoint inhibitors that were used. And again, a benefit for progression-free and median overall survival in this group. Again, if you enrich for PD-L1 status, substantially better responses and overall survival than those who were PD-L1 negative. So this is just a summary slide looking at these little boxes of what's happened really since February of this year, and the three of the drugs were approved between May 1st and May 18th of this year. The atezolizumab trial, though, that was the one that didn't meet the overall survival primary endpoint, but I think that in all fairness, we have to give it more time and look at subsets and try to tweak out who in that group might benefit. The data has not yet been presented yet, but will before the end of the year. And finally, the question is which PD-L1 or PD-L antibody, PD-1 antibody do you use? And I think that the answer to that question is we really don't know. If you just look at response rates, which is not the be-all and end-all, they're shown in that last column. The trials were similar but not exact, and the comparisons will never be made head-on. But suffice it to say, we have a lot of leads here and a lot of new directions to go. As I think of where we would go next, I think it's clear that you can actually combine some chemotherapies with PD-L1 or PD-1 agents. That's been shown, at least in the case of pembrolizumab, with frontline therapy. The idea of giving induction platinum and gemcitabine or maybe docetaxel and then going on a maintenance therapy like we've done with some of the mutational agents in lung cancer is another area of exploration. And then the combination of IPI and NIVI, as Edgardo was talking about lung, and as you'll hear in melanoma, is also a strategy. So I'm out of time here. So I had a summary slide, but I'm out of time. But anyway, thank you.